Good morning, everyone. Good morning. Welcome to Geriatric's Grand Rounds. Our speaker is Dr. Kaci Johnson. The topic is Mind the Gap, Closing Medication Gaps in Transitions of Care. But a couple of announcements before we get started. Our next Grand Rounds is going to be on the 29th of May. It's Dr. Sarah Tietz, and the topic is Care That Ages Well, Program Development Framework for Transforming Geriatric Care. Other announcements, you'll receive an email with the link of the recording today. After today's presentation, there will also be an evaluation. Please make sure to complete those. They're extremely valuable for our speakers. And please submit questions in the chat or Q&A boxes anytime during or after the presentation. A quick introduction. Dr. Johnson is a University of Colorado Skaggs School of Pharmacy graduate. She completed her PGY1 residency within the VA Eastern Colorado Healthcare System and remains with the VA as a PGY2 pharmacy resident in geriatrics. Upon graduation, she will transition into a clinical pharmacy role in an ambulatory care within the VA down south in, where is it? In Castle Rock. Warm welcome for Dr. Johnson.
Good morning. Get this. All right. So I apologize. I'm a little sniffly this morning, but I'm going to try to get through it without doing that too much. But like Dr. Gilhooly said, I'm talking about medication gaps during transitions of care. For some learning objectives, we'll briefly do some definitions, but I know we've already had a transitions of care discussion that was wonderful, so we'll just do an overview of that, as well as describing some of the harms associated with medication discrepancies during transitions of care, identify both medications that can contribute that are high risk and patients that may be at elevated risk of experiencing harms related to medication use and discrepancies. And then lastly, go over the outcomes of a quality improvement project that was completed for veterans enrolled in home-based primary care within our VA system that were returning home from hospitalization. So just some brief definitions. Transitions of care is just any transfer of a patient from one care setting to another. And with each of these, it's just an opportunity for us to ensure improved patient safety across the continuum of care. Medication reconciliation is a comparison of a patient's accurate medication list with any admission, transfer, or discharge orders. And this should include the drug name, dose, route and frequency of administration. And as we'll talk about a little bit more, poor or non-existent medication reconciliation is a significant risk factor for discrepancies as well as adverse drug events. And then last definition is just a discrepancy in medication, which is any difference between medication use history and the active medication orders. So this table comes straight from the World Health Organization Safety and Transitions of Care document, and they provided based on literature showing the different rates of medication discrepancies at differing areas of transitions of care. So one study they included found that 62% of patients that are transferring between units within a hospital system are experiencing unintentional medication discrepancies. And this is data from a systematic review of randomized and non-randomized trials. It was 83 trials that were evaluated, and that's why there's such broad ranges of discrepancy rates between all of these different sections. So anywhere from like around 3 to 98% of patients within these studies were found to have discrepancies. Some of the studies included did also provide a potential impact of these discrepancies based on a 3-point rating scale, anywhere from no or minor harm associated, moderate or severe harm associated with these discrepancies. And so what they found was around 20 to 80% of patients across the board had minor or moderate harm that was potentially associated with the discrepancies, and then severe harm was anywhere from 0 to 24%. And with these studies, overall, one thing to think about is that they're observational for the most part. Not a lot of these ones were randomized controlled trials, and there was a lot of heterogeneity regarding interventions as well as what usual care would be considered as. And so overall, the impact on clinical outcomes isn't necessarily fleshed out within these trials. So we'll talk about that a little bit more as we go along. So the common types of medication discrepancies, most notable is omission of medications. Across a lot of the studies that I reviewed, this is the most common experienced discrepancy, is just a medication that's not on the med list that's being taken. But patients can also just be on an incorrect dose formulation. There could be considered a discrepancy as interactions, contraindications, and duplication based on that World Health Organization document. But also follow-up other than omissions, like the second most common discrepancy seen is continuation of a stopped medication. It's just not as frequent as omission. So harm associated with medication use, medication-related harm can affect up to 1 in 30 patients in healthcare, and over 25% of these cases are thought to be severe or life-threatening, and we'll go into the data on that a little bit more. Half of avoidable harm in healthcare is thought to be related to medications, and specifically in the United States, based on CDC data, adverse drug events are estimated to cause more than 1.5 million emergency department visits annually. Additionally, medication discrepancies have also been linked to medication errors, delays in receipt of medications, as well as rehospitalization. And one study notes anywhere from about 46 to 56% of all med errors are occurring during these transitions of care. So who is at risk of having harm associated with medications? So a lot of different people may be at risk. Those that may be at highest risk are patients that have polypharmacy. They're using high-risk medications, which we'll talk about, multimorbidity, lower health literacy, as well as possible cultural and language barriers. An individual's risk does increase with the number of medications that they're taking, the use of high-risk medications, and the presence of morbidities. And patients with complex medication regimens and older adults are among those that are at the highest risk. And on the left, I just included, this is not an all-encompassing list of high-risk medications. The first section of bullets is from the ISMP ambulatory care high alert drug list. The other section includes multiple different drugs that we may commonly see in patients based on the Beers criteria recommendations, in addition to the Centers of Medicare and Medicaid of what medications they consider to be high risk or potentially inappropriate. I will say the CMS list is incredibly long. It's like hundreds and hundreds of drugs. So I would probably lean more towards the shorter list of Beers criteria, but there are a lot of things for us to consider with medication use for our patients. So this is more of that data that supports the 25% severe or life-threatening medication harm in patients. So this is data from a systematic review and meta-analysis. That was those observational studies. They looked at preventable medication harm, and their primary outcome was prevalence of preventable harm. And that included any sort of adverse drug event, drug reaction, allergy, incorrect dosing, anything along those lines is what was included. And they had 81 studies with a pooled sample size of almost 300,000 patients, with about 6.4% of those experienced at least one medication-related harm, with 2.5% of those being considered preventable. Around 20,000 of these harm incidents were reported, with almost 40% of them being deemed preventable. And the highest prevalence rates of these preventable incidents of harm were seen in the elderly patients, or those seen in the ICU or surgical care units, and those in the emergency department as well. And they also listed the severity of harm or potential severity, which is pretty similar, of about 40% for mild and moderate, and about 25, 26% for severe. I also included the figure on the right. This is just from 20 of the studies. They did a top 5 ranking of medication groups associated with harm. So this is the #1 rank across the studies that included this ranking system. And so as you can see, there's definitely multiple medications that are repeated in the #1 ranking. So cardiovascular drugs being repeated, I think 4 times in there, NSAIDs, antipsychotics, definitely medications that we see a lot in practice. And I'm sure a lot of us have seen adverse drug events or reactions associated with them as well. So this study was a little bit more recent. This was done last year. It is an observational cohort study that looked to describe the frequency and types of medication discrepancies between post-acute care facility discharge, specifically, and patients that are going home. And these were for older adults that were hospitalized at a specific medical center. They had to go home with home care. They couldn't be in long-term care and assisted living. They could have med assistance. And these patients did receive a phone call follow-up 7 days post-discharge from the acute facility from either a pharmacist or a nurse practitioner. And they also wanted to identify any specific patient factors that might be associated with discrepancies during this specific transition. So for the patients included, the median age was about 77. The range was 70 to 84. Majority patients were female, with anywhere from 11 to 18 medications being used prior to admission. And that number went down to around, or 11 to 20 prior to admission, 11 to 18 at discharge, with around median of 8 changes in medications during this admission, ranged anywhere from 6 to 12. And the median number of med changes that they noted was between hospital admission to through discharge from the post-acute care facility. And so for the results, they did find that 98% of the patients that they looked at had at least one medication discrepancy, with a median number of 7 per person. Majority of these were omissions, around 700, followed by additions of medications, around 500, and then dosing discrepancies. 92% of patients had at least one discrepancy with a potentially inappropriate medication, and that was deemed based on the 2015 Beers criteria and stop criteria as well. So this is also from that study. They just kind of completed a graph showing the medication discrepancies by drug classification. And so the ones that are included here are those that had at least 20 or more discrepancies for patients. And as you can see, I know it might be somewhat small, but vitamins and supplements is the largest portion that were found, which I think sometimes patients may think that these are benign products to use, though we do need to consider that they can be associated with liver and kidney damage, as well as interactions with prescription medication. So it's very important for us to know about these and ask about these when we're reaching out to patients. And then about 37% of all of the discrepancies, other than the vitamins and laxatives, was more of like antihypertensives, opioid and non-opioid analgesics, antihistamines, those sorts of things. They also, like I mentioned, they looked at any risk factors that may increase someone for having discrepancies. And so they did find that the most significant risk factors for discrepancies at the 7-day follow-up was the increasing number of discrepancies seen on hospital admission, as well as patients that had worsening functional impairment, and if they were receiving assistance with medication. So this next study was also done last year. It was a retrospective cross-sectional study, and they looked at the rates of unintentional medication discrepancies, as well in the association with post-discharge emergency department visits within 30 days. So a little bit more info about the possible harm associated with these discrepancies. And so they included patients that were 65 and older. They ranged from anywhere from 71 to 83 years old. They had to be on chronic meds and admitted to the ICU. And the median number of chronic medications was pretty low, around 5, anywhere range from 3 to 7. Around 15% of patients were on high-risk medications, and the comorbidity index score that they provided, a majority of patients had a score of 1 or less, which is associated with a 96% 10-year survival rate. So overall, these patients seem fairly healthy. They are older, but not on as many medications as we may see in some older adults, and their comorbidity index is pretty low. So they did find 951 discrepancies involving around 650 medications, and this occurred within 68% of the total number of patients evaluated. They did see that there were discrepancies at each transition within the system, so admission, transfer, and discharge, with discharge being the largest percentage, around 50%. And they did find that those with discrepancies were at a higher risk of coming back to the ED within 30 days. Overall, 14% of the patients did come back, but those that had discrepancies were at a 2-fold increased risk. And they also noted that patients with more chronic medications and the use of medications for the musculoskeletal system were more likely to have discrepancies at these transitions of care. So to go a little bit more into what possible harms might occur, I figured we could talk about a couple patient cases as we go through just to see a little bit more of the detail associated with what might happen with medication discrepancies or errors that occur during these transitions. And so, briefly, some of you are more aware than I am of the seniors clinic process, but patients that are seen by seniors clinic providers, they're admitted to the hospital for more than 24 hours and they're discharged home without like hospice, or they're not sent to a facility. They receive a phone follow-up by a pharmacist within 24 to 72 hours, depending on their discharge date, to review medications, go over the hospitalization, and kind of follow up with the provider to make sure or triage the situation to see when patients need to be seen by their primary care provider. So this one patient that I actually worked with when I was in seniors clinic last month, he's an 81-year-old male. His past medical history is listed there. His medications are also listed. I didn't provide doses on everything just to save space a little bit, but the more pertinent medications are listed with doses. He was admitted for 7 days here at UCH, and he did undergo a planned XLAP with distal pancreatectomy and splenectomy. He was followed by the acute pain service while he was in the hospital, and he did have an epidural in use until 1 day prior to discharge. I reviewed the meds he was receiving for pain while inpatient. Compared to his prior to admission, he was not getting tramadol while he was in the hospital, and he got kind of different doses of Dilaudid, ketorolac, methocarbamol, and oxycodone kind of here and there throughout the admission, but not a whole lot of opiate use. And then some of his labs and vitals are listed there. So here are his discharge medications. So the ones noted in orange or yellowish, these are the new medications that were started upon hospital discharge. And then the rest of them are just continuation or lack of change to his prior to admission medications. So I did just want to take a brief pause and see, poll the room, as well as if anybody wants to speak online or in the chat, please feel free. Are there any like initial thoughts or concerns that you have when looking at this list? What's the first like alarm bell that goes off when you look at this list? He has 2 opioids. Yep, I agree with that. No laxative. Also agree with that. Yes. Yes, he is on prophylaxis with enoxaparin. Yeah. Um, Definitely things that I thought about as well when doing the review before I spoke to him. So now we can chat about what actually happened when I called this gentleman. So when I spoke to him, the discrepancies were he's not taking the acetaminophen at all. The tablets he has at home is actually 500 milligrams each instead of the 325, which not a huge discrepancy, but a difference. He also told me he was not taking the enoxaparin, and he was not taking his gabapentin either. And then upon review of his tramadol, he told me prior to admission, he was actually taking 100 milligrams every 8 hours instead of 50 milligrams every 4 hours. Let's see, and there was nothing in the chat on that one. I think we have someone off mute.
I'm 15.
It's not me.
Okay. So I know this is a lot. We'll kind of just go through it little by little. So when I called this patient, like I said, there were some discrepancies that were noted. He also reported feeling fuzzy and confused, which was very obvious throughout our conversation. He also reported, despite taking both oxycodone and tramadol on a scheduled basis, he was not missing doses of those. His pain level was consistently around a 5 to 6, and he felt like his oxycodone benefit was wearing off around 1 to 2 hours early within that 6-hour window. He had no idea what the indication for enoxaparin was and was not using it. He did not remember being educated about how to use it or inject it or anything along those lines. And when talking about bowel movements, like what was mentioned, he does not have any laxatives or bowel regimen ordered. He had no recent bowel movement, didn't know when his last one was, and he was not taking any medications for constipation at home. So when I talked with him, we discussed resuming the Tylenol at 1,000 milligrams 3 times a day scheduled to kind of help with more multimodal pain control. And based on the fuzziness and confusion that he was reporting, I really did not feel comfortable with having him resume gabapentin on top of the dual opioid use until we at least talked to his PCP. And luckily, this patient did have a form of polyethylene glycol at home. So we recommended he was agreeable to resuming that and taking it twice a day to really prevent that opioid induced constipation. And then while we were on the phone, we talked about the enoxaparin and we walked through how to do those injections, and he did that while we were on the phone together. And so for follow-up, while I was talking to the patient, I was messaging the primary care provider about my concerns, and luckily he was available. And so we talked about the confusion concern and the use of both tramadol and oxycodone. I was definitely concerned about accumulation in this patient with taking that medicine every 4 hours since he was tolerating it fine previously. And so PCP agreed, reached out to the surgical provider just to kind of touch base, see if we could make a better pain management plan. And we actually ended up, the tramadol was discontinued. The oxycodone was optimized, so we increased the dose and the frequency to better cover his pain. And then the gabapentin was resumed just for his bedtime dose to help him sleep a little bit better. So that was a lot. And this patient did not necessarily have a medication related harm or adverse event, but he did experience an adverse drug reaction, likely with the confusion that he experienced, which was luckily we caught that pretty early right after his discharge. So to kind of switch gears just a little bit from different health systems. So home-based primary care within our VA, our process is a little bit different on how we manage these transitions and medication reconciliation. And so this is just kind of an overview of our team. We have quite a few different disciplines that we work with: geriatricians, nurse practitioners, RNs. We're lucky enough to have psychology, occupational therapy, and dietitians as well within both of our regions, and social work. Between both our northern and our southern regions, the team is caring for a little bit less than 300 patients at a time generally. And our provider panels can range from anywhere to 45 to 75 patients at a time. And the RNs care for up to 35 patients each. And we're seeing these patients specifically in their home. And we do have 3 pharmacists, 2 in the northern region and 1 in the southern region, that help support our providers with these panels. This, again, is a lot of information. This is just our guidance and directives of what we base our processes on within the VA. And so the VHA Directive 1345 kind of goes into what the medication reconciliation involves and who the responsible parties are. And so within this directive, medication reconciliation is a comparison of medication use with medication lists, documentation of that information within the health record, and communicating with VA and non-VA team members, and also providing written information on medications at the end of each encounter for our veterans. The provider shoulders a lot of this responsibility based on this directive. They're responsible for completing medication reconciliation, documenting the plan to assess discrepancies, assisting with maintenance of the medication list, and documenting and reporting adverse events. When it comes to pharmacist responsibility, the role within this directive is much more of a supportive role to the providers to do medication review or provide counseling and education as requested. Additionally, we have a standards of practice document specifically for home-based primary care, which requires patients should be questioned about medication changes and over-the-counter medication use at every single visit. Written changes should be provided to the patient, and the pharmacy profile should be updated. And the med list should be available in the patient's home, and a new list, if any changes are happening, need to be provided at every visit. And patients should also be educated that this needs to be readily available to their providers. So this is just an overview of the recent process, or the return from absence, temporary absence process within home-based primary care. We won't talk about all of this. A lot of it is just documentation requirements. But overall, our team gets notified by the hospital, caregiver, family member, or veteran if they're absent from the home for a medical purpose. and specific documentation has to occur with that. And when patients do come home and the team is notified, we have 2 business days to outreach the veteran, just to see how things are going, kind of triage the system, the situation, and then we have 7 business days for the patient to be seen either by video visit or face to face to just check in once they've returned home. And if veterans do not return home within a 60-day time frame, those patients are discharged from home-based primary care. So we'll get into why we reviewed our current home-based primary care MedRec processes. So the literature on interventions for successful care transitions is pretty heterogeneous, like I talked about before. There is a systematic review of randomized controlled trials specifically looking at transitions of care in older adults that were hospitalized, and they looked at different modes of intervention, whether that's on admission, throughout admission, and at discharge, and multiple different modalities of interventions. They found that prolonged follow-up interventions may better reduce adverse outcomes for older adults, and prolonged would be interventions at more of the stages throughout that transitions of care process. And they also found that for these older adults, self-management of medications, as well as telephone follow-up and medication reconciliation were the most effective interventions that they saw. Based on the Joint Commission safety actions and statement, they recommend that pharmacists should be involved in medication reconciliation whenever possible. And that's based on an older trial that included around 1,500, 1,600 patients. And they found that with pharmacist involvement and outreach, there was a number needed to treat of anywhere from 9 to 15 patients. And this benefit was seen up to 365 days post-discharge. And so it was to prevent hospitalizations and readmissions and ED visits post-discharge. So it's one of the only studies, at least that I found, that had more of a significant and sustained reductions in re-representation to the healthcare system post-discharge. And the Joint Commission also recommends that we ensure medications are included in the written forms and transition or plan and discharge summaries for our patients. So when it relates to our home-based primary care process, our pharmacists are not really involved in the transitions of care and MedRec process. And the main reason for that is they're just not in the home. And so our pharmacists work remotely and do most of their care over video visits and telephone visits. But they did note during their quarterly reviews, they do reviews every 3 months on their veterans within their panel just to see what med changes are occurring and any updates and recommendations they can make. And pharmacists noted inconsistencies that they identified during their med reviews. And they also identified delayed medication discrepancies for transitions of care. And we'll talk a little bit more with this next patient case, specifically looking at the discrepancies that occurred for one of our veterans post-discharge, but unfortunately it wasn't caught until months later when an annual or quarterly review was done by a pharmacist. So this is our 94-year-old male veteran. His past medical history is listed and some pertinent vitals and labs. These labs are from a more recent visit from one of the home-based primary care nurses. So his blood pressure is pretty well controlled. Pulse is normal. His pain score is 5, which is a little elevated for him. And then just one thing I want to point out, I'll talk a bit more about it later, is his A1C is 6.8%. So for his timeline of events, unfortunately, he had a syncopal episode at home, and he was not found until about 14 hours later. And so he was hospitalized for about 10 days, and due to some deconditioning, he ended up going to a skilled nursing facility for about 3 weeks after that. In his diagnosis list, he did have some complications like skin infection. He did get C. diff while he was in the hospital, unfortunately. And so upon return home, he was sent home with home health care and medication assistance. The home-based primary care RN did visit this patient within a reasonable amount of time once we were notified that he was home from the post-acute care facility. And he actually had multiple visits with the RN between his discharge and when I completed his MedRec review on December 4th. So I know this is a lot, We'll do a quick repeat of our last polling question. Any first thoughts, concerns, or any red flags looking at this medication list or things that you would prioritize when doing a review for this veteran? And I know it's a lot more, so take your time to look through it. I heard oxycodone, yes, and he does have Percocet too. We've got another dual opiate patient. The methocarbamol, yeah, I would agree, especially in combination with the opioids. His insulin, yeah. Fish oil, Imodium, great. I agree. All of these things are things that we were thinking about when reviewing this patient's chart. And his meds, of note, all of them are managed by home health. He's not a great historian. He does not know what medicines he takes or what they're for necessarily, their doses. So it adds just a little bit, a layer of complication when working with him. So again, the highlighted medications were the more immediate concerns when completing my review and going through his discharge documentation of both his post-acute care facility med changes as well as his hospitalization. And so upon review, he went to the hospital for a syncopal event. He was hypotensive throughout that entire admission. So none of his blood pressure medications were given to him throughout the hospitalization or the post-acute care facility time. Unfortunately, when discussing this with the home health agency, they did not receive any sort of medication updates. And so upon his return home, he was resumed on all of his pharmacotherapy. In addition to the blood pressure medicines, his blood pressure or his blood sugar was very well controlled while he was in the hospital and in the post-acute care facility. So he was not requiring any insulin use. And again, when he went home, he was resumed on his insulin. And his dose wasn't very high. I think it was like 8 units for some reason, like twice a day is what he was taking. But still concerning that he wasn't requiring it. And that there's some concern that maybe that low A1C less than 7 is being driven by hypoglycemia in this veteran. The other thing, so the pain medications were a little bit more difficult to flush out. He was followed by a non-VA pain facility. They dropped him, unfortunately, during his hospitalization and acute care facility time because he didn't have follow-up during that time frame. So I think there's just some miscommunication. So no one was following him for chronic pain management. He was running low on pain medicines. He ended up only having oxycodone at home, but he was rationing it because no one was prescribing him anymore for his pain. So not as involved as the last one when it comes to the number of bullets we went through. But I reached out to the HBPC RN to see if they could go out sooner rather than later to complete an in-person medication reconciliation, just because it was so hard to see what was really going on in the home over the phone between the veteran and the home health agency. Within our quarterly review, there were definitely action items at the top of that note, just alerting the PCP to the medication discrepancies and concern regarding follow-up on the fact that he was resumed on these therapies, follow-up on blood pressure and appropriateness of just continuing these agents in general. I also recommended additional follow-up regarding the pain management and maybe taking on the patient as a pain patient for us instead of sending him back out into the community. And then also requested that once the med list was updated, it definitely should be faxed over to that home health agency so that they know what the patient should be receiving. And we actually ended up following this veteran long-term for diabetes follow-up as well. So based on veterans like this one and what we've seen with discrepancies and inconsistencies, we wanted to complete an evaluation of medication reconciliations during these transitions of care. And so this was a retrospective observational quality improvement and quality assurance project. I did chart reviews of veterans between April and October of last year, those that did have an absence from the home. The purpose of this was just to look at the completion rates as well as the accuracy of MedRec within our team and just identify any areas where we could improve. We included patients that were enrolled within HBPC. They were returning home from a temporary absence of less than 60 days, and they couldn't be disenrolled, obviously, or they were excluded if they were out of the home for respite care or vacation purposes. So for patient characteristics, average age for our patients is about 77 years old, with a majority of patients being male, pretty standard for the VA. The average number of home medications was a lot higher than some of the other studies that we've talked about. So our patients are on average around 20 medications. And within most of our patients are in the northern region, as well as just our panels is larger in the north versus the south. So about 80% are up here. And then the average number of absences for veteran was about 3, with anywhere from 1 to 5 absences occurring. And there were about 16 patients that really contributed to these higher numbers of repeat encounters. The average duration of absence was a little less than 10 days. And the number of absences, most patients just went to a hospital, with a fewer number of patients that did have both hospitalization as well as post-acute care facility treatment. And a majority of patients that did go to the hospital were seen at a non-VA facility. So there were a total of 93 absences that were evaluated between 65 veterans. The number of discrepancies that were found across all of these encounters was 66, which accounted for about 34% of the total encounters. The average number of discrepancies per absence was a little bit less than 1. And you might notice between the north and the south region, the south did have a larger average of discrepancies of 2 versus about 0.4. And that could be possibly because our VA hospital is located here on this campus in the northern region, and medication changes and updates are automatically made in the chart for those veterans. So less likely to have discrepancies. Um, the number of discrepancies per discharge location was 80% in hospital, followed by about 20% for those that had hospitalization and time in a rehab facility. You'll notice the number of discrepancies is 13, which isn't a 1-to-1, but the number of patients that had a hospital and rehab stay was also 13. So just the rates overall were a lot higher for those patients. And the average number of discrepancies per facility was 1 for those patients versus about 0.7 for those in just the hospitalization. The figure on the right is just types of discrepancies. So pretty similarly to the studies we've talked about, omissions of medications from the chart were the most common, around 50%, followed by continuation of stopped medications at about 30% of the time, with incorrect dose around 20% and incorrect formulation more uncommon with only 1 patient. Some additional results that were collected. So there were 6 veterans that unfortunately didn't have any sort of documentation available from their hospitalization, from their non-VA facility. 4 veterans did not have any home-based primary care follow-up post-discharge at the time that I had completed their review. And there were copy-paste errors that were identified during review. So full notes, including older medication lists, were copied forward, making the MedRec more inaccurate. I also looked at communication associated with discharge, whether that was communication from the facility to home-based primary care or pharmacist communication. So overall, the team is being notified a majority of the time when veterans return home from an absence, with only 20 patients not being. We didn't get notified for those. There were 13 patients that there was no documentation in the chart that the veteran returned home, but we followed up with them in an appropriate time frame anyway. And then for pharmacist notification from providers when they are seeing these patients post-discharge, it was pretty uncommon. Only about 15% of encounters had a pharmacist tagged to the note for follow-up. So some of the limitations of this particular study is just it was retrospective. We had a pretty small sample size. Again, like I mentioned, the confounder of the fact that we have our VA hospital up here in the northern region, and in the southern region, it seems like access to those non-VA facilities is a little bit more difficult. They're less likely to be available within our JLV or review system for non-VA facilities. So that affected the availability of non-VA records at times. And unfortunately, based on time constraints, we just weren't able to collect more information on high-risk medication use to maybe stratify in the future what patients may be the best to outreach or have pharmacist intervention. So that's something we may be able to look into more in the future. So overall conclusions from what we looked into is that documentation of med reconciliation as well as clinical reasoning for discrepancies can be inconsistent at times within our system. The most common discrepancy found, similarly to other studies, is the omission of medications from the electronic health record. differences and discrepancies between regions, like I said, may be related to the VA hospital location, and pharmacists are really not routinely involved within this process. And certain veterans may benefit from a consult to the clinical pharmacist during these transitions. So based on the results of this, we presented this information to the home-based primary care team, and they were very receptive to what we found. And so we completed an anonymous survey for the providers within the team, just going over what their position was, what their best practices and barriers may be when completing MedRec and documentation during these transitions of care visits. We also wanted to know how much time it's taking them to complete MedRecs, how long they're in the veteran's home for these visits, and if they're combined visits, like for annual as well as transitions of care, and just getting a little bit more information on any barriers regarding communication with non-VA facilities, as like home health agencies, assisted living facilities as well. So we did get responses from 8 different team members in addition to just having an open discussion during our meeting and presentation. And so here are some of the barriers and best practices that we identified. So availability of documentation, like I mentioned, it may be difficult to access discharge documentation in the home, whether that's medication lists or discharge paperwork. Some noted that discharge paperwork was available, but it didn't have clinical reasoning as to why certain changes were made. Additionally, I think one of the biggest barriers is the health record access, the fact that providers are not able to access the chart while in veterans' homes due to inability to access internet, slow processing speeds. And one provider mentioned they really don't want to spend time trying to log onto their computer when they could be spending time taking care of the patient. They also noted other concerns like time constraints, whether that's within the visit or during documentation, and interfacility communication between home health agencies and non-VA facilities. So based on the discussions that we had and the survey responses, Dr. Hornay was wonderful about looking into updating the processes to see if we can maybe improve on our current medication reconciliation process. So similarly to the previous program that we used, we're notified of the veteran's return home. The provider, case manager, NP, RN should be gathering hospital records as soon as possible. And if for some reason they're unable to view hospital records, they should be reaching out to our program support assistant to obtain documents from the discharge facility. The medication reconciliation should occur, whether that's the case manager, RN, NP, and that should be done within 48 hours of our notification that they returned home. And updates to the medication list within the health record should be made as soon as possible or prior to the home visit. And then once these things are done, providers should be reviewing all their completed lists, whether that's supplies, medications, any other tasks following this transition, and fax any updated medication lists to the parties that would require them. The newer box in this plan is when to consult the pharmacist. So I'd say this is something we're going to continue to work on, but we're considering patients that have multiple medication changes being an indication to tag the pharmacist to the transitions note. If a patient has an absence with more than one transition, if their absence is longer than 7 days, or if there's significant changes to kidney function that might warrant a re-review of medications to ensure dosing is appropriate. So there's still definitely, this is very early days of this. There's still maybe some questions to be answered about if case managers or RNs and NPs should both be doing MedRecs and cross-checking each other. But I think once this gets implemented, we'll survey the team again or just kind of request feedback as this goes along to make sure providers aren't necessarily being asked to do more work to make these improvements. The other change that occurred based on what we found was just updated communication just to make it a little more seamless for providers to communicate with non-VA facilities. And so this is our care coordination note where providers can fill out this note with any medication changes or supply changes that can have the program support assistant fax this to any facility that would need it. And so it's a little bit easier of just filling out any medication changes, refills, other instructions like the fax number, any other information the PSA may need, and then just tagging them on this note so that they're not necessarily as responsible for getting back to the facility and faxing records. So next steps is just kind of complete the implementation of this new process and kind of gauge providers' interest in this, make sure there's no barriers that we're adding for them, and then eventually reevaluate our medication reconciliation completion and documentation once we've made these changes. And maybe just further investigate which patients may benefit more from pharmacist intervention and consider future evaluation possibly of admission communication with non-VA facilities. So making sure we're faxing providers in non-VA hospitals med lists that are accurate when we're notified that they're admitted so that they have appropriate information while they're in the hospital as well. That is everything. Thank you so much for listening. I'm happy to take questions.
Thank you so much, Dr. Johnson. Do we have any questions in the audience or comments?
Thank you so much, Kaci. Appreciate your presentation. You had that slide where the gentleman had, it was a whole slide with meds.
Yeah.
And he didn't know what he was taking. And I would just love to hear your perspective and your approach to those who have 20 plus meds and
Mhm.
aren't sure what they're taking and how you sort of clean that up and try to improve things.
Yeah, I think the the best thing I can say with that is trying to provide as much detail to the veteran when talking with them of especially covering as needed medications because obviously home health isn't managing those. And if you're able to, if patients are more aware of their medications, they don't have like significant cognitive impairment, trying to provide as much like education as possible. And I think if it's pertinent, like with that one veteran, scheduling follow up of like this patient could definitely benefit from pharmacist follow-up for diabetes management. Maybe just a little bit more frequent phone calls would help him understand what his medications are for. But I think in also some instances is just getting as much information as you possibly can and then kind of contacting any other parties that you can, like the home health agency. So for him, I talked to the person who manages his meds, got more information about what's in the home, what it looks like if I can't get as much information from the patient.
Thank you so much. I'm curious if you could talk a little bit about where you think this MedRec should take place in an ideal state, whether that's in the hospital, if it's at home, like where we could optimize this in an ideal world. In
Mhm.
my mind, like having been a resident, done discharges and definitely made mistakes, I'm sure, what supports you would imagine we could have or should have in a hospital-based system, so there's not even this like 2-day delay where there's med errors. Like, is there a system in place that you have heard about, or could you imagine where we could do this a little bit better from the beginning?
Yeah, I think there it's hard with the studies that we have with the different interventions that they've done have been so incredibly broad, whether that's phone follow-up, video follow-up, home follow-up, if they're just doing chart review, if they're doing medrec. I think doing medrec and education would be like my top priority at any transition of care point. I think patients should be as involved as possible. And because those that know their medicines, know what they're taking them for, have more autonomy and they may engage more with the healthcare system. So I think just providing more education and having more contact. One of the studies that I talked about, the specific one in older adults with those different interventions for MedRec, they did specifically note that between differing providers, whether it's geriatrician, pharmacist, nurse, they didn't necessarily find any difference in like readmission rates or any significant difference between providers of who should be doing the MedRec. So I think there's a lot of opportunity for just like a well-trained person that understands meds and can maybe like flag errors that patients are providing, to just have more contact with these people. I hope that answers your question.
Thank you. My question was to, in a way, follow up to Carrie's regarding the patient that had the whole page of medication. Besides the oxycodone and the opiates that you pointed out, what jumped out to me was the syncope coupled with both taking nitroglycerin and insulin. and the patient had controlled blood pressure. So was there ever, is there, in that situation as a physician, is there consideration that they have multiple medications on board that could be dropping blood pressure?
Yeah, I would 100% agree with that. Yes, that's definitely a consideration. It was honestly like the biggest consideration I had for him other than like the insulin. Just because when you see someone that's 94 that did have an event like that get restarted on all of those medications, it was very concerning. And especially being on like a telephone visit, I can't see if he's euvolemic. I don't know. So it is a big concern. And I would say it ended up with that provider, some of the recommendations were just like, are these still appropriate? He had heart failure with preserved ejection fraction, and he was on a beta blocker with no other necessary indication. So it was definitely like one of my top recommendations to just follow up and make sure continuation is safe for him.
Thank you so much, Kaci. Warm round of applause, please. Thank you so much.